Dear colleagues, my name is Luciano Baronciani and I'm working at the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center in Milan, Italy. Together with my colleague and co-speaker, Dr. Omid Seidizadeh from the University of Milan, I would like to welcome you to the e-learning program of the European Association for Hemophilia and Ileal Disorder. This is Module 4 and our topic is von Willebrand disease. In the first part of this webinar, I will speak about the diagnosis of von Willebrand disease. Then I will illustrate a case of a complex diagnosis on VWD in a large family. And in the third part, my colleague, Dr. Seidizadeh, will give you an update on the literature on von Willebrand disease. At the end of each presentation, we will propose you a short test. Let's start with the first presentation. Von Willebrand disease is a common and heterogeneous bleeding disorder, and its accurate diagnosis presents numerous challenges. The focus of this presentation will be the diagnosis of von Willebrand disease following the 2021 joint guidelines of the American Society of Hematology, the International Society on Thrombosis and Hemostasis, the National Hemophilia Foundation, and the World Federation of Hemophilia. The joint guidelines were prepared by a panel of multidisciplinary experts and are intended to support patients and clinicians in their decisions about VWD diagnosis. Based on the STH classification, von Willebrand disease patients are divided in three types. Type 1 and 3 are characterized by a partial or complete deficiency of von Willebrand factor, whereas Type 2 is due to qualitative defects of von Willebrand factor. Type 2A is characterized by decreased or absent high molecular weight multimer. Type 2B results from a gain of function in von Willebrand factor that increases its affinity for platelet. Type 2M is due to decreased von Willebrand factor interaction with platelets or collagen, and Type 2N is characterized by markedly decreased binding affinity for factor VIII. The panel approached this guideline within the framework of this classification system with the addition of one subtype, Type 1C, which is caused by increased von Willebrand factor clearance. This is the algorithm proposed by the panel to obtain the diagnosis of von Willebrand disease. It should be specified that these guidelines focused on the most common inherited forms of von Willebrand disease. We will go through the algorithm step by step following the panel indication, which, based on the strength of the evidence, are either recommendations or suggestions. In order to do so, we will divide the algorithm in 4 parts. The first step in the algorithm for a patient suspected with VWD requires the use of bleeding assessment tool, BAT. On this aspect, the panel considered 3 different situations. For low probability of von Willebrand disease, for example for patients seen in primary care, the panel recommends using a validated BAT as an initial screening test to determine who needs specific blood testing over non-standardized clinical assessment. The panel remarks that this recommendation applies mainly to adult women, as the data supporting the use of a BAT as a screening tool is strongest in this group of patients. For intermediate probability of von Willebrand disease, for example, patients who refer to the hematologist, the panel suggests against rely on the BAT to decide whether to order specific blood testing. For patients with high probability of von Willebrand disease, for example, patients who have an affected first-degree relative, the panel recommends against rely on the BAT to decide whether to order specific blood testing. These indications are given to exclude the possibility of missing affected individuals who have not yet manifested bleeding symptoms, such as men and children. Now we move in the second part of the algorithm, Specific blood testing for von Willebrand disease refers to the von Willebrand factor antigen, the platelet-dependent von Willebrand factor activity, and the factor VIII coagulant activity. For the diagnosis of von Willebrand disease, the panel suggests newer assays that measure the platelet binding activity of von Willebrand factor, like the von Willebrand factor GP1BM or the von Willebrand factor GP1BR, over the von Willebrand factor histocytic factor assay. The panel remarks that the von Willebrand factor activity assays should be performed in a laboratory with appropriate expertise. To confirm the diagnosis of type 1 von Willebrand disease, the panel recommends von Willebrand factor level of less than 30% regardless patient's bleeding, or von Willebrand factor level of less than 50% for patients with abnormal bleeding. On this regard, the panel remarks that von Willebrand factor level refers to antigen and/or activity. Local laboratory cutoff should be used if it is lower than 50%. ABO blood group specific reference ranges are not required, and von Willebrand disease diagnostic testing should be performed when patients are at the baseline state of health. For patients with suspected type 2N von Willebrand disease in need of additional testing, the panel suggests using either von Willebrand factor factor VIII binding or target genetic testing. Both approaches are not available at all centers, but in either case it is possible to ship a sample to a reference laboratory for the analysis and establish the diagnosis of type 2N von Willebrand disease or mild hemophilia A. This part of the algorithm is starting with the evaluation of the platelet-dependent von Willebrand factor activity to antigen ratio. Using this ratio, it's possible to discriminate between type 1 and type 2 von Willebrand disease. To confirm type 2A, 2B, or 2M for patients with abnormal initial VWD screening, the panel suggests to use a cutoff of less than 0.7 instead of less than 0.5 of a platelet-dependent von Willebrand factor activity antigen ratio. Following the algorithm, patients with a von Willebrand factor activity antigen ratio higher than 0.7 are diagnosed as a type 1. The identification of patients who have type 1C has management implications, as these patients may require von Willebrand factor concentrates to treat or prevent bleeds. To confirm increased von Willebrand factor clearance for patients with suspected type 1C, the panel suggests using a DDVP trial with 1 and 4 hour post-infusion blood work, instead using von Willebrand factor propeptide to antigen ratio. For patients with previously confirmed type 1 von Willebrand disease who now have von Willebrand factor level that have normalized with age, the panel suggests reconsidering the diagnosis as opposite to removing the diagnosis. The panel remarks that aging and comorbidities are known to increase von Willebrand factor levels. However, the association between the increased von Willebrand factor levels and bleeding symptoms is not established. The last part of the algorithm regards the diagnosis of type 2 von Willebrand disease. As mentioned earlier, the algorithm considers as type 2A, 2B, or 2M all patients with a von Willebrand factor activity to antigen ratio lower than 0.7. The panel remarks that some patients with type 2 have normal von Willebrand factor antigen and platelet-dependent von Willebrand factor activity, but a low von Willebrand factor activity antigen ratio. To diagnose type 2 von Willebrand disease for patients suspected of type 2A, 2B, or 2M in need of additional testing, the panel suggests either von Willebrand factor multimer analysis or von Willebrand factor collagen binding antigen ratio. The panel remarks that most laboratories that do the collagen binding assay use type 1 or type 3 collagen, which is known to be a surrogate for the presence of von Willebrand factor high molecular weight multimers. The diagnosis of type 2B von Willebrand disease for patients suspected of type 2A or type 2B in need of additional testing, the panel suggests target genetic testing over low-dose ristocyte-induced platelet agglutination. Genetic testing and RIPA are both able to discriminate type 2B from type 2A patients. Both approaches are not available at all centers, but RIPA requires a fresh blood sample. Therefore, sample shipping is not possible. So, at the end of this presentation, I would like to propose you a quiz. Which of the following statements is correct? For patients with family history, the panel recommends rely on a BAT to decide whether to order specific blood testing. Strong recommendation. The panel suggests newer assays that measure the platelet binding activity of von Willebrand factor, like the von Willebrand factor GP1BM or von Willebrand factor GP1BR, over the ristocytic factor activity for von Willebrand disease diagnosis. For patients with suspected type 2N von Willebrand disease, the panel suggests using the von Willebrand factor factor VIII binding over target genetic testing. And finally, the panel recommends a von Willebrand factor level of less than 50% regardless of bleeding to confirm the diagnosis of type 1 von Willebrand disease. The correct statement is number 2. Thank you for your attention, and please feel free to contact me with any question or regard of this presentation.